Hello everyone, welcome to the RSNA Radiographics podcast. My name is Shaimaa Fadl and I'm a radiologist at Virginia Commonwealth University Health System. I'll be reviewing the article titled Cardiac MRI of Hereditary Cardiomyopathy. Hereditary cardiomyopathy is a group of diseases of the cardiac muscle that are characterized by the presence of underlying genetic mutation. Cardiac MRI is central to evaluate those patients with cardiomyopathy owing to its ability to allow evaluation of many different tissue characteristics in a single examination. We are going to review cardiac MR features of hereditary cardiomyopathy and the role of MRI in risk stratification, treatment, and prognostication. Starting with hypertrophic cardiomyopathy or HCM. HCM is the most common genetic cardiomyopathy with an estimated prevalence of 1 in 200 people. It is an autosomal dominant disease with variable penetrance. The most affected genes are those encoding for sarcomere filaments, specifically myosin heavy chain 7 and myosin binding protein C gene mutations are accounting for most cases of HCM. Approximately 40% of cases of HCM can occur without an overt family history or identifiable genetic mutation. Cardiac MR HCM is characterized by myocardial hypertrophy more than or equal to 15 mm, arising in an undilated left ventricle. Lesser degrees of hypertrophy more than or equal to 13 mm can be diagnostic in patients with gene mutations. The hypertrophy most often asymmetrically involving the basal anterior septum, and in a counterclockwise pattern of involvement can be seen from the base of the heart to its apex. The function is usually hyperdynamic with obliteration of the cavity during systole. Left ventricular outflow tract obstruction, which is defined as a gradient of 30 mm mercury or more, or a planimetric measurement of 2.7 square centimeter. Associated features include systolic anterior motion of the mitral valve and basal septal hypertrophy. Systolic anterior motion of the mitral valve, or SAM, produce approximation of the mitral valve leaflets and or chorda tendineae to the basal septum, and a mitral regurgitant jet that is directed posteriorly. Late gadolinium enhancement, or LGE, which is present in 60 to 80% of patients, is commonly seen at the RV septal insertion sites. Characteristically, patchy mid-myocardial enhancement involving the regions of greatest hypertrophy. Additionally, the pattern of LGE allows differentiation of HCM from other types of cardiomyopathy with a left ventricular hypertrophy. For example, it differentiates HCM from Fabry disease, transthyretin cardiac amyloidosis, and Danon disease. Elevated native T1 and extracellular volume values when seen in areas of the myocardium that are remote from the LGE are suggestive of diffuse interstitial fibrosis. Moving to Fabry disease. Fabry disease is a rare X-linked lysosomal storage disorder that is characterized by deficiency of alpha-galactosidase enzyme. The typical cardiac MRI findings include concentric left ventricular hypertrophy, the accurate measurement of which is important for early detection of cardiac involvement, assessment of treatment eligibility, and prognostication. Basal inferolateral midwall LGE is seen in approximately 50% of patients and is characteristic of Fabry disease. Native T1 values are substantially lower in patients with Fabry disease because of myocardial glycosphingolipid accumulation. With disease progression and development of fibrosis, native T1 values may be elevated and may correlate with the areas of LGE at the basal inferolateral wall. The characteristic low T1 values in patients with Fabry disease can help to differentiate it from other causes of patterns of hypertrophy, as can the LGE pattern. Cardiac MR plays an important role in assessment of eligibility for treatment, risk stratifications in Fabry patients, monitoring of disease progression, and follow-up after treatment. Now moving to transthyretin cardiac amyloidosis. It is an autosomal dominant disease with variable penetrance. It results from a single nucleotide gene mutation to the transthyretin protein. The age of onset is variable, ranging from the 3rd to the 8th decade of life. Cardiac involvement occurs in approximately 25% of patients with the mutant type of transthyretin cardiac amyloidosis. Structural abnormalities in patients with cardiac amyloidosis include atrial wall thickening more than 6 mm, biatrial dilation, ventricular wall thickening more than 12 mm, and note that pleural and pericardial effusions are common. On contrast-enhanced inversion time scout sequence, cardiac amyloidosis demonstrates abnormal myocardial nulling that occurs before blood pool nulling, which is very specific for the diagnosis of cardiac amyloidosis. Late gadolinium enhancement images, or LGE, in cardiac amyloidosis shows a global subendocardial enhancement pattern, which can be transmural or patchy. Patients with cardiac amyloidosis have markedly elevated native T1 values and also extracellular volume values. Technetium-99 pyrophosphate scintigraphy can be used as a problem-solving tool for differentiating transthyretin cardiac amyloidosis from the light chain type. Now let's talk about Danon disease. Danon disease is a lysosomal storage disease that's X-linked dominant and is characterized by mutation of the gene encoding for the lysosome-associated membrane protein, resulting into lysosomal accumulation of glycogen. 81% of patients with Danon disease are males and 19% are females. Male patients usually present in adolescence, while female patients can present in the 3rd or 4th decade of life. Female patients usually have a milder form of the disease, and cardiomyopathy can be an isolated manifestation. Pre-excitation syndrome, specifically Wolff-Parkinson-White syndrome, may be seen on EKG in 81% of the patients. On cardiac MR, Danon disease demonstrates massive myocardial hypertrophy that can reach 4.4 cm and is mostly concentric. Asymmetric hypertrophy is less common, and a dilated pattern is rarely seen in females. Danon disease is characterized by extensive late gadolinium enhancement. The pattern of enhancement is usually extensive subendocardial and mid-wall enhancement, with some areas showing near transmural LGE. There is relative septal sparing, which is a typical feature in 88% of the patients, while lateral wall and apical enhancement are present in almost all the patients. Native T1 and extracellular volume values are elevated and correspond to the areas of LGE. Let's talk about familial dilated cardiomyopathy, which is characterized by an enlarged heart with systolic dysfunction. The estimated prevalence of dilated cardiomyopathy is 1 in 250 people. The familial forms account for approximately 1/2 of those cases. Many genes have been identified that are associated with dilated cardiomyopathy, including the gene that encodes for the titin. Cardiac MRI is the reference standard for quantification of the LV dilation and dysfunction. Functional valvular regurgitations can occur secondary to ventricular remodeling with decreased leaflet coaptation. Contrast-enhanced cardiac MR detects complicating thrombi. Late gadolinium enhancement may not be visible at MRI in many patients with dilated cardiomyopathy, but when it is seen like a linear mid-wall stripe pattern of LGE, particularly in the septum, is a poor prognostic indicator. Dystrophin-associated cardiomyopathy, including Duchenne muscle dystrophy and Baker muscular dystrophy, which are X-linked diseases associated with mutations of the recessive genes encoding for the dystrophin protein. Duchenne muscular dystrophy is the most common and most severe form, while Baker muscular dystrophy is the milder form. Imaging in early childhood may show only a mild reduction of left ventricular function without morphologic abnormalities. With patient aging and progression of the disease, the characteristic MRI features appear. Global left ventricular hypokinesis and dilation, thinning, regional wall motion abnormality of the lateral wall, particularly the basal and mid segments of the left ventricle. These same regions often show abnormal late gadolinium enhancement at contrast-enhanced MRI, typically with a mid-wall or subepicardial pattern, although transmural involvement can be seen in patients with advanced cases. Elevated native T1 and extracellular volume values can be used as indicators of early and diffuse patterns of fibrosis. Arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy is an inherited cardiomyopathy that is characterized by fibrofatty replacement of the myocardium. The prevalence of the disease ranges from 1 in 1,000 to 1 in 5,000 people. It is an autosomal dominant disease with incomplete penetrance. Arrhythmogenic cardiomyopathy used to refer to RV predominant disease. However, biventricular and LV predominant disease are other forms. Arrhythmogenic right ventricular cardiomyopathy is caused by mutations in the genes encoding for the desmosomal proteins, including lacophelin, lacoglobin, desmoglen, desmocolin, and desmoplakin. Consequently, this results in impaired desmosome function, particularly under mechanical stress or exercise. Patients with arrhythmogenic right ventricular cardiomyopathy, or ARVC, usually presents between the second and fourth decades of life, and the disease can manifest with ventricular arrhythmia or sudden cardiac death in young adults. The 2010 revised task force criteria used to establish the diagnosis of ARVC. It is based on multiple categories, including tissue characterization, arrhythmia, electrophysiologic abnormalities, and family history. MRI can provide only one major or one minor criterion, and therefore cannot allow a diagnosis of ARVC to be established in isolation. Cardiac MRI is important in evaluating RV dilation, impaired function, and regional wall motion abnormalities. RV wall motion abnormalities include echinacea, dyskinesia, or desynchronous RV contraction, and these abnormalities are included in the revised task force criteria. Late gadolinium enhancement of the RV has been reported in approximately 2/3 of cases and correlates with inducible arrhythmia. Left ventricular predominant or even isolated left ventricular disease is increasingly recognized, particularly in patients with desmoplakin mutations. Now let's talk about iron overload cardiomyopathy. Iron deposition in the myocardium initially results in diastolic dysfunction and restrictive physiology, but over time, systolic dysfunction occurs and predominates. T2 star imaging is central to the detection and quantification of iron overload cardiomyopathy. Iron deposition in the myocardial tissue causes a lower T2 star values. The degree of iron loading correlates with the decrease of T2 star values. At 1.5 Tesla, a T2 star value of less than 20 milliseconds is clearly abnormal and indicates iron loading, while a value less than 10 milliseconds indicates severe iron overload. The use of T2 star mapping is now widely used to guide chelation therapy, which has been shown to reverse the disease progression in affected individuals. Iron overload results in low native T1 values, which is helpful in detection of iron overload in patients with normal or borderline T2 star values. A minority patients develop myocardial fibrosis related to a severe iron overload. which is detectable as late gadolinium enhancement and elevated extracellular volume values. In conclusion, cardiac MRI is the imaging technique of choice in the diagnosis of hereditary types of cardiomyopathy. With a combination of standard cine and delayed enhancement cardiac MR and parametric mapping, most hereditary types of cardiomyopathy can be accurately characterized. Thank you very much and see you in the next podcast.